Yes, thank you very much. I would like to thank for the honorable invitation. From the case that you are going to see, Professor Grant has to be blamed at least for 80% of this, and I will explain the reasons as to why. So first of all, he was visiting us and we gave him the prime time, and we started the CTO procedure at 3 o'clock in the evening for the consideration, which always has to be part of what is happening. So it's a 69-year-old male. He has these risk factors that you are doing, multiple of them. Moderate renal impairment. He got in a quite young age PCI in the LAD. It was, I think, 14 years ago. So, and then presented in another hospital with inferior STEMI. He got primary PCI and a very big dominant RCA. And then in the same catheterization, they found that the old stent in the LAD had been occluded. The ejection fraction was 50-55% with preserved anterior wall motion. The patient was not very symptomatic, but he had some shortness of breath on exertion. He was also very keen, because patients sometimes pushing their luck, and you will see also why, to have this vessel open. He was an elegant man, and in September of 2023 failed. There was a failure of recanalizing his LAD. And then he came and he was referred to us, and we decided to take over the case. So I will not present you the initial procedures, just what we did. So here you see bilateral injection. He didn't have right radial artery due to the previous interventions. So we went femoral and left radial, as you can appreciate here. There is a stent in the RCA. It's a very dominant vessel, providing collateral circulation in distal LAD. And what you don't see well in this projection is there is a tight stenosis in the LAD supplying this big diagonal branch. And you see here that there is an stent occlusion. The distal LAD was not really a very impressive vessel. What I would like to bring to your attention as a focus is that the collateral circulation consists of these two, or one septal in my view. This vessel here, the second one, should be an epicardial collateral. And there is an epicardial end-to-end collateral from distal LAD with a distal PDA. So what happened is that usually the instant occlusion cases are not so, I would say, I would consider them not easier, but definitely you have the guide of the stent, you know where to go. There are some more options with knuckling, some other devices. But anyway, this challenge was proven to be particularly difficult. And as you can see, it was underestimated. We tried initially with undergrade wire escalation and Bamba microcatheter supported by different wires that they went subintimal. Then we took a dual lumen microcatheter, a Sasuke. If you can see the detail here, you see a Gaia 3 with the ball tip detached. You see the separation between the very tip and the radio pack. That means that the wire was also killed. Anyway, one way or the other, I managed at this point to cross. And yeah, Dr. Grant outside was teaching out of live the cath lab. And when I started struggling, because nothing was moving on, you can see here the LAD problem. One thing that you have to focus here, see the crossing of the wire in the with the stent. So it goes into the middle of the stent at the beginning. That it takes a course that we cannot confirm whether it's outside of the strut stents, but definitely it's in the corner of the stent here. Then enters properly. Every balloon failed. One thing that you have to cause that was not very well visualized at that time. This is an gold, turnpike gold. We used 5, 6, 7 balloons. Mohamed came in the room. We have this, we have that. We were pushing, we were pulling. But you know, in these cases, every time that you push a balloon, the guy thinks catheter's back, the wire comes back. When you release the pressure, the wire goes in. Anyway, we were failing completely, or I was failing. At that time, he decided that it's too late. He left the lab. Probably he saw something that I didn't. And anyway, around 6 o'clock, we started to go retrograde because nothing, this was an acrossable lesion. You see assumed black wire is crossing. Turnpike LP is crossing. We cross the lesion retrogradely in a fashion that it is a little bit different. You can see at least that this wire here is different from the other one, ending up in the guiding catheter extension. and it goes into the guiding catheter extension, it goes into the other grade guiding. The wire was externalized, and then the guiding was advanced, no problem to cross retrogradely the stent, and then after externalization of wire, pre-dilatation, and a stent was placed after IVUS control, and kissing balloon over this. We kissed also the bifurcation of the left main because the circumflex was a little bit impinged. So that was an acceptable result, but seeing a little bit further down, there was a whiff. So the patient was stable at that time. So we did an echo and there was 1 centimeter pericardial effusion. We took an injection here, and you can clearly see that something is leaking. Not completely clear because the circulation now, when you open a vessel which is a CTO, the circulation, collateral circulation is compromised, in a good way compromised, because you're losing the feeling. Anyway, by bilateral injection, it's obvious that there is something going wrong here. So it took some time actually to puncture, thinking a little bit this, that. Anyway, tap was done. There was no really hemodynamic compromise, not a very big amount, around 200 ml was aspirated and was given through the femoral vein. And that's the situation, as I told you, the collateral circulation that I analyzed before. This should be an epicardial collateral. This is a septal, and this is another epicardial. So we took the Mamba microcatheter, so the same microcatheter, 0.14, and with T-tip injection, you clearly see that there is a leaking here. We give a little bit more distal the tip injection. It's not always the very best to tip inject there because you might have a perforation that you make it bigger. But here it was unclear that it was leaking, and finally it's obvious that it was leaking from this collateral, as I told you, the apical collateral from distal PDA to distal PLA, because the 2 other collaterals were going into this direction. You can clearly see it. We made it bigger by the tip injection when you pressurize it. So what happened is that unfortunately we didn't follow. This is a coil that it is neurocoil. We developed the neuro service now for strokes. So for me, it was a good experience. The coil is called Optima. It was available it's a detachable coil. It was 2 millimeter by 3 centimeter. I'll show you from the other side because that's a question here. Completely sealing of the flow, but there was still leaking, and we knew that because in the CTO thing, and it was discussed previously, you might need to do bilateral coiling because the collateral provides both ways the perforation side. You can clearly see now from the right coronary artery there is residual leaking. You see the contrast going there. Sometimes very difficult to recognize the vessel that it is going. Here you see the detail of the collateral. And that's an assumption, it's still frame as to where it was leaking from. So what happened is that you see how the coil is coming. You see also that there are proximal markers. Essentially, you put the coil in the position that it is necessary. You move the microcatheter back up to the marker, and then you coil it. I'll show you the device, how you release it. So this is a 2x2 coil, and then a second one also released. And you see that gradually the flow starts getting slower, and finally it's completely sealed. The experience with this coil was very positive, I have to say. And this is a microcatheter that we used for the PCI. So with these kind of coils that you need to know exactly what coils are there fitting the microcatheters, and actually you save money by having compatible devices. Anyway, just to not make the long story short, you see here the injection from the right, the pericardium became dry, and through this bilateral coiling, finally we solved the problem. But clearly, look at that, what I missed at that during the procedure. You push a balloon, this was before, and then when you're relieving the tension, and although I had in mind with these very aggressive wires, see the wire, you release and just dumps down like a knife and really perforates the collateral. That's this specific coil that I told you, and this is a device here to release it. This is it. One of the things that it was discussed, you have to have the full portfolio. This is the release device. There are others that they will be discussed, but the message that I want to close, you saw the picture and it's not necessary to stay longer. You have to have a lot of devices on that and you have to know them. And the cath lab, it was mentioned, has to be prepared.
Excellent. Thank you.